Our next speaker is Suanna Steeby Bruinooge, MPH, who is the Division Director for Research Strategy and Operations in the Center for Research and Analytics at the American Society of Clinical Oncology, ASCO. Leadership responsibilities with ASCO include development of ASCO's research agenda, as well as research conduct and standards. Ms. Bruinooge works closely on research standards with a broad range of partners, including the Food and Drug Administration, the National Cancer Institute, patient advocacy groups, and researchers themselves. Ms. Bruinooge has a Master's in Public Health and Policy from George Washington University's Milken Institute School of Public Health.
I see I forgot to take draft off my slides, so you'll have to forgive me for that. Thanks, everyone, for being here on a wet and cold morning, not exactly the snow that you might have thought you were going to encounter. So I appreciate the invitation this morning to come and speak to you all. ASCO, I'm speaking on behalf of really a team of my colleagues at ASCO. We've done a lot of work and with many of your organizations as well, and I'm pleased to share the results of some of that work. Let's see, here we go. So just to give you an overview of what I'm going to talk about, I'm going to talk about supply and demand, and a lot of ASCO's research, as you might imagine, focuses on oncologists, but I'm also going to share, we did a study with the Oncology Nursing Society, the PA organizations, both the American Academy of PAs and the PAs in Oncology, as well as the Advanced Practice Society of Hematology and Oncology. We looked at the roles of advanced practice providers, and so I'll go over that. I'm also going to talk about geographic distribution. My colleague has done some work looking at Medicare data and where oncology practices are located. I'm also going to talk a little bit about our teams in oncology, teams in cancer care delivery project that we did with the National Cancer Institute. And finally, ASCO has done the second annual, last year we did the second annual consumer survey, and so I'm going to go over, weave some of that data into my discussion as well. So ASCO has done 3 different workforce studies now, 2 of which were done when I was with the organization in 2007 and 2014, and we did one prior to that. But as you can see, we all pretty much found the same thing in all of our studies, and certainly Dr. Brawley went over this very eloquently. The reasons for the rise of cancer cases is really largely related to 2 things. It's the aging of the U.S. population, but it's also the good news that people are surviving longer and living longer with a cancer diagnosis. And so that means we have more people to take care of, which is certainly a good problem, but it's certainly challenging from a caregiver, from both a clinician perspective and also a caregiver perspective. And so these curves, this is by no means a precise science, looking at workforce projections. And so in both of these cases, we looked at different scenarios, different things that might happen. But the shortcoming of workforce studies is always that you're basically applying current service use to the future. And you can always, more or less count who the future clinicians are going to be. You never quite know when people are going to retire, and you never quite know how care is going to change. And so this is a very imprecise science, but it gets across the point that you heard from Dr. Brawley, that we're going to have more cancer patients and more cancer survivors, and we're not going to be able to keep pace of that with the number of clinicians. This is another aspect that's significant in the oncologist community. And I'll just say this is actually no different than medicine overall, as well as nursing overall. Although nursing, you'll hear from Brenda later, nursing takes a little bit different tact because of the differences in the workforce. But oncologists oncology as a path started in the early 70s. So we have a lot of people who are nearing retirement, and we don't have as many people coming up from behind to replace them, although those curves are getting closer as we go along. So the other thing, and I think that these might be my former slides now that I'm looking at this, but I'll just keep going along here. So in terms of the study that we did of advanced practice providers, so we were looking for how many advanced practice providers, so these are nurse practitioners and physician assistants who are caring for oncology patients. And this is actually a very challenging thing to do. With oncologists, we can look at them and see them in the workforce because they're the ones who are billing for the services. NPs and PAs, on the other hand, might be delivering some of the exact same services, but they don't show up in the billing data because of the way that we have structured the billing. They're paid at 85% of the physician pay rate, and that incentivizes healthcare systems to bill services under the physician. And so they're harder to find. And even when they are in the billing data, their specialty is nurse practitioner or physician assistant. It's not whatever subspecialty they might be practicing in. So we did this analysis trying to find out how many nurse practitioners and physician assistants were working in oncology. And we found that there were basically anywhere from 5,400 to 7,000. And we couldn't really get a more precise number unless we went out and did a literal head count. We also found, and again, I don't think any of this will be surprising to many of you who have worked in a clinical care setting, that thanks, Ruth, that that NPs and PAs are spending 85% or more of their time on patient care. So and this is when you ask them about whether they're in patient care, researching, teaching, administration. A lot of them are spending the majority of their time on patient care. So they're very significant members of the workforce. And for those of you I know who are in academic medicine, the nurse practitioner or the physician assistant is the one who keeps your clinic running when you're going out to speak at meetings or doing research or working with your colleagues. So we all know quite well the role that these people, that nurse practitioners and physician assistants are playing. We also found that many of them practice independently or in combined visits. So let me just say a word about what that means. Independently is not actually that it's like in primary care where there may not be a physician. They may have a clinic all by themselves. In oncology, it's actually there's a physician who's present, there's a physician who's on the team, and they're there for consulting, but largely nurse practitioners or physician assistants in many cases might work independently, have their own caseload, or they might be in what are called combined visits, where they do certain visits independently and certain visits with the physician. And for those who do, and this is one of the other things that we found is that for those who do independent visits, they actually do quite a few more visits than those who do combined visits. And then finally, those who are in shared visits. So a shared visit is you have the physician right in the room, more or less, or maybe quickly following, the nurse practitioner, or they might come in the physician might come in at the end of the visit. And in that model, we get the fewest visits done. And it's simple math, really. If you have someone who's functioning and really serving as a full member of the team, they're going to get the most care done. We also found that satisfaction is very high, and also collaboration and teamwork are really key and to making this, to accomplishing clinical practice. And I put and research because this really was a partnership that we did with the other professional societies. Oh, I can't advance. No worries. Okay, so I'll just skip ahead. Thanks, Ruth. So oncology practices by size. So this is some analysis that my colleague Kelsey Kirkwood has done, and it's looking at the size of oncology practices. And as you can see, the practices that are in Florida, there's a lot of practices in Florida, and I'm glad that Dr. Brawley showed his maps early, because now you can sort of lay those maps alongside these maps sort of in your head. And as you might imagine, the oncology practices are also where the elderly people in our country are located, Florida, California, et cetera. There's a lot of oncology practices in the Northeast, and these also do correspond to where academic centers are, because of course you need to be training a lot of oncology fellows subsequent to that. So this is the data that we based this analysis on. It's called the CMS Physician Compare database, and this is where members of the public can go and see quality information on their oncologist and who are participating in the Medicare program. So I should note that this is only based on physicians who are treating Medicare patients. So I'm focusing mostly on hematologists, medical oncologists, and hematologist oncologists. This obviously isn't a good data source for pediatric hematologists, oncologists, and it certainly has a lot of caveats, but we do believe that this is probably one of the best places to look at the oncologist workforce. So as you can see, there are about 12,500 oncologists overall, and they are distributed among about 1,800 practices in the U.S. Now, one thing that was very surprising to us about this, if you look at the graph or the figure, the bar chart here on the right, a lot of oncologists are actually in small practices. And I should note that this 1 to 2, 3 to 5, that's the number of hemoncs in the practice, but that is based on the number of physicians as well. So we were looking at the practices according to whether there was a hematologist, oncologist in the practice, but this is really the number of physicians overall. So you see that many oncologists are still, there are a lot of oncologists who are working in smaller practices. And there is, as I mentioned earlier, a maldistribution, if you will, of where the physicians are located and where the patients are located. And this is based on the consumer survey that we did. And certainly these are a survey of caregivers and cancer survivors. And those people who are located in areas that are not near major cities, also, not surprisingly, have a more difficult time accessing care. And this is rural according to that person's own definition. One of the projects that we did as a result of our workforce studies and then in addition, our work on advanced practice providers was we were actually approached by the National Cancer Institute, and they wanted to do a project looking at team-based care in oncology. And so what we did was they had fortunately done a lot of the evidentiary analysis in the literature, looking at how teams are defined, especially teams in medicine, in clinical care. And we were taking some of those learnings and applying them to oncology. So a clinical team here is defined as 2 or more people who interact dynamically, interdependently, and adaptively to achieve a common goal shared within the context of some larger group or organization. And I put on the bottom of the slide here all of the different things that we developed as part of this project. But really the challenge in oncology is that we're not only teams working together in one care setting, we're also teams of teams as the patient goes from surgery to radiation to oncology to palliative care. And if you're not in a healthcare system, it's often incumbent on the patient really to connect those dots. And so, one of the questions we sort of had over and over again in this project was, do patients and caregivers want to be part of the team? Are they part of the team? And, it's sort of like the saying that happens here in Washington. If you're not at the table during the policy discussion, you're probably what's on the table getting carved up. And I think certainly, I fortunately am fortunate enough never to have, myself interacted with cancer, but like many of us, I have family members who have. And I think certainly if patients aren't involved in that discussion and thinking about and participating, sometimes they feel like they're being acted upon, but they're not part of the team. Finally, this is, again, a little bit more data from our consumer survey that was done last year. And, I just share this data to say that there are consequences if patients aren't part of the team and aren't voicing what their preferences are. And some of those potential consequences relate to, are they actually, Dr. Brawley talked a lot about what we know and we're not applying. But now we're seeing things crop up in consumer surveys that there's more faith in alternative medicines than there are in medicines that are evidence-based and known to be effective. And then additionally, we all know, and there's been a lot of data thanks to many researchers and patients, about cancer's financial access and challenges. And of course, Dr. Brawley shared that as well. Where there are disparities, they're often related to someone's ability or lack thereof to access care. And of course, this financial burden is one that crosses generations and crosses families, unfortunately. And I think this is definitely a lot on the minds of patients who are going through this process. And so I think really, and I'm not a clinician myself, but as clinicians and caregivers, I think we should be thinking about how does the patient or how does their caregiver want to be part of the team? How do they want to be involved in this discussion? So finally, I just want to say thank you because I'm part of a team, and the work that I presented here today is, while I'm privileged to present it and share it with you all, I only did it because I'm part of an effective team myself. So I want to thank my colleagues as well. Thank you.